Understanding Depression for Primary Care.
Good morning. My name is Susumulu Shoinka. I'm a psychiatrist and clinical associate professor of psychiatry at the University of Pennsylvania. I'll be sharing some thoughts with you around depression, which is an extremely common psychiatric medical condition that has a broad range of effects and is known to be the leading cause of disability globally. One important factor is that depression is very often unrecognized, unfortunately, and it can lead to unnecessary suffering and even death. And so, learning how to recognize and treat depression, particularly in primary care settings, but also in the workplace, is crucial. Now, what are some I think it's important to set the context. We are really in the midst of a unrecognized, I think it's increasingly more recognized now, mental health crisis. So 1 in 5 adults within the United States where I live and practice experiences a mental health condition in a given year, whether or not it's recognized or treated. Globally, according to the World Health Organization, 1 in 8 individuals experiences a mental condition annually. Of those conditions, anxiety and appears to be the most common, but depression, like I mentioned earlier, is the leading cause of disability globally, which is significant. Also, we statistics show that about 1 in 10 children experiences a serious mental or emotional disorder. And I think most telling over the last decade or so since COVID, we've really seen a steep rise in the rates of mental distress among young people globally. And this unfortunately includes the steep rise in suicide, particularly among young people and young men in particular. Now, depression is, like I said, among the commonest of medical conditions globally, but it's not one disease state. It's not one homogeneous condition. It's a spectrum of disorders. And depressive symptoms can be part of other medical conditions, which we'll get into that in detail. Now, symptoms can range from mild to severe. As I mentioned, they affect over 350 million people globally. And unfortunately, depression appears to be common in females, particularly really all around the country. Well, how do you diagnose depression? How is this diagnosis made? Well, there are 5 core symptoms, five or more out of a cluster of 9 symptoms have to be present and present daily or nearly daily for over 2 weeks. The first is the core symptom of depression, which is simply sadness, and it's mood symptoms that don't react to circumstance. Another core symptom is anhedonia. Anhedonia is a loss of ability to enjoy things. That is, things that ordinarily would produce pleasure or satisfaction do not. And this can be pretty striking. Also, significant weight loss or weight gain, over 5% of the person's body weight. Unintended weight loss or weight gain is often present. Sleep disorders, that is, trouble sleeping, trouble falling asleep, trouble staying asleep, can be crucial. Difficulty, what's called psychomotor agitation or retardation. Psychomotor retardation means a person just appears slowed down in their thought process, in their communication, in their movements. Conversely, individuals can also show signs of psychomotor agitation, and you see this in some types of atypical depression. Fatigue is a striking feature of depression. Feelings of worthlessness, inability to concentrate, or inability to make decisions, and recurring thoughts of death are these are the 9 core symptoms of depression. As I said, five out of these 9 symptoms must be present daily or nearly daily for at least 2 weeks. It's important to recognize that in many cultures, within and outside of the US, some people they don't report mood symptoms. They may report primarily physical symptoms such as back pain, and in young people in particular, depression may manifest as change in behavior and irritability. Historically, depression had been among other mental health conditions. There has always been this question about whether they are real illnesses or whether they are sort of just all in your head. Well, in a sense, that's true. It's all in your head in the sense that people do actually there's actually evidence for brain changes that happen in depression. This is a PET scan that was from a study that was conducted at the Mayo Clinic. And this is images used with permission. And it shows the brain of a depressed person on the left hand, and on the right hand, you see the brain of somebody who's not depressed. And what you can see is that brain on the right is a normal person. That's blood flow from injecting a radioactive ligand into the bloodstream and doing a PET scan. Well, this brain on the right shows normal blood flow. The brain on the left shows reduced blood flow, but including in some critical brain areas. And so it is true that it is all in your head, but it truly it's true that depression it has very, very significant biological markers. Other markers include that people experience pain. We do see lower levels of a metabolite of serotonin in the brain fluids of cerebrospinal fluid of people who complete suicide. We see elevated levels of cortisol in people with depression. Now, earlier I made the point, and I think it's important to make this point again, that depression is a set of symptoms. It is a unique and distinct medical condition, but people can have symptoms of depression as part of other medical and psychiatric conditions. So this includes, one of the big ones is bipolar disorder. Bipolar disorder, that term literally means two poles, up and down. Well, the lower pole, the critical diagnostic feature of bipolar disorder, whether it's bipolar 1 or bipolar 2, is the experience of a single lifetime episode of mania or hypomania. So a person, once they have even a single episode, is diagnosed with bipolar disorder. However, it's not all, and these episodes typically manifest early in life, but it's not always the case. Sometimes people will not have a manic episode until their 60s. I've personally seen that in my own practice. And so they may have depressive symptoms for most of their lives. In addition, people with bipolar disorder typically, not always, but typically experience more episodes of depression than mania. And so you can be confronted or be helping to treat a person who has treatment-resistant depression, but they actually have a bipolar disorder. And one of the ways you can, one of the key features of bipolar disorder is a person may have a family history. Other atypical features include marked psychomotor changes, onset in early adolescence. Now, why is this important, particularly in primary care? Well, for providers in primary care, depression impacts everything, literally every medical condition. It increases the prevalence of chronic pain. When it's present, people who experience cardiovascular events such as strokes or myocardial infarctions don't do as well. The rates of mortality are higher when depression is comorbid, is also present. You see worse outcomes in nursing home patients who are depressed. You see poor adherence in the treatment of chronic conditions such as diabetes, hypertension, and you can often see people very often treat unrecognized or even sometimes diagnosed depression with alcohol use and other types of SUD, very commonly cocaine or other stimulant use. I think it's also important to recognize that depression can occur as a result or in comorbid with other medical conditions. You see this very often with endocrine disorders. You also see it with neurologic disorders or neurologic conditions. As I mentioned earlier that people sometimes will self-medicate to treat themselves or to treat their unrecognized or untreated depression. Well, the converse is also true, that substance use oftentimes will trigger or create or result in the manifestation of depressive symptoms. And then oftentimes when you have chronic medical illnesses, chronic pain, autoimmune conditions, and so on, people will often trigger depression and make these conditions harder to recover from. So, serious medical illnesses may make depression worse. They may precipitate new onset depression. They may mimic depression. Substance use disorder, mood disorders due to general medical conditions and major depression frequently overlap. And you can see common manifestations of chronic illness such as fatigue or anorexia, weight loss, hypermotor retardation, or difficulty concentrating can look like depression. And sometimes, to make things even more complicated, depression frequently will result in non-compliance with treatment or worsening of physical conditions. So, and then finally, we recognize a syndrome known as demoralization, when a person has essentially used up all their emotional, psychological capabilities, their resources to fight a disease. So sometimes you see this in cancer or chronic pain, and they just don't have very much left to give. And so this can look somewhat like depression also. And as I mentioned, it's pretty common in medical settings, in comorbid medical conditions. Now, I think it's important to talk about some some common medical conditions that are associated with depression. So I mentioned endocrine conditions, type 1 diabetes, Addison's, Cushing syndrome, hypothyroidism, infectious diseases. We've known for a long time depression sometimes is the first manifestation of certain kinds of cancer, and is commonly comorbid with hepatitis C, HIV, cardiopulmonary diseases such as CHF, asthma, COPD, neurological conditions are a big category that are commonly coexist with depression. And then, like I mentioned, new cancers such as pancreas, head and neck cancers, and cancers of the lung people can experience depression. I think it's also important to talk about medications because this is something we don't often think about. And there's a long list of medications that can trigger or worsen depressive symptoms. So antihypertensives. Not that this will happen all the time, but it can happen, and it's well worth looking out for this effect in individuals who are treated with these medications. So calcium channel blockers, alpha-methyl-dopa, quinethidine, ricipine. Some of these medications are not so frequently used anymore, but we still know this. Retinoic acid derivatives, some anticonvulsants, some anti-migraine medicines, some hormone preparations. Chantix, which is used to treat for tobacco cessation, NSAIDs, opioids, that is very frequently prescribed, barbiturates, benzodiazepines, beta blockers, progestins, propranolol, steroids, interferons, interleukins, levodopa, chemotherapeutic drugs, steroids, very common. Now we know that there is a significant downstream impact of untreated depression with medical primary care settings, medical conditions, and in primary care settings. Worsens outcomes for pretty much all medical conditions, reduces overall health, as I said, and may increase risky behaviors as well as reduce adherence to treatment. We know there's more rapid progression of HIV, increased mortality. We've talked. All right. So how do you treat depression? Let's kind of get to nitty-gritty. There are the evidence, if you put it together, indicates that individual treatments with multiple modalities, that is basically all the tools that we have, seems to work better than treatment with just one modality. So what do I mean? We know we have the talk therapies, which we call psychotherapy, and there are many types. There's, just off the top of my head, there's supportive therapy, there's interpersonal therapy, there's cognitive behavioral therapy, there's trauma-focused CBT, there's prolonged exposure. There are things like activation and commitment therapy, and it's so many of them. Combining these talk therapies, psychotherapies, with biological treatments such as medication, such as ECT, such as TMS, such as intranasal ketamine, and addressing the social context, addressing things that are actually going on in the person's life. And then lifestyle changes such as exercise, improved sleep, sometimes adjusting your diet, sometimes attending to nutrition. These can result in a significant shift in the person's overall their outcomes, their response to treatment. So I always advocate, as a first step, do a thorough assessment to address, to search for any of those underlying causes that we talked about, keeping in mind, any sort of temporal correlation. So if depressive symptoms began right around when a medication started, or right when a certain medical condition was discovered, you might want to you want to know that, because one might be connected to the other, and it may not necessarily change your treatment, but it's helpful to know. If you're in inpatient settings, you always want to rule out delirium, because delirium or altered mental status or confusion can look like anything. You also want to investigate the person's personal and family history of both anxiety and depression. You want to review their medications. As I mentioned, you want to review for any use of drugs, and sometimes people don't feel comfortable sharing this. And nowadays, there's been is somewhat of an increase or relaxation in societal attitudes towards drug use. And sometimes there's a correlation. You want in your physical examination, look for signs of drug use, needle marks or perforated nasal septum or other signs. You want to do a thorough workup. So EKG, echo halters, parathyroid hormone, TSH, CMP, CBC, and so on, and check for signs or markers of alcohol use. And then you want to proceed right into treatment. Like I said, treatment is most effective when it's combined and integrated with the rest of the person's care. So we know that there's a sort of more supportive therapy, but you really want targeted treatment. And of all the therapies we have, interpersonal therapy and cognitive behavioral therapy seem to stand out. You may also consider psychodynamic therapy if the person has some real sort of internal conflicts, or a history of trauma therapy if there's a history of trauma, which is often the case. You also want to, sometimes in terms of treating pharmacotherapy or medication management, sometimes what you want to do is remove things, eliminate things that may be causing these conditions, or may be associated with these conditions. Very commonly, so when I worked in inpatient consult psychiatry, one of the things we often did was remove things. So steroids are very, very commonly associated with mood symptoms, for example, but sometimes it's more subtle. So, and you do want to keep in mind SSRIs are the mainstay of treatment. That's serotonin specific reuptake inhibitors are now the mainstay of treatment, but the response rates are about 60%. And so you want to keep in mind that we do have access to a fuller range of treatments. And we do know that combinations of antidepressants sometimes are more effective than single medications of different classes, or sometimes two medications from the same class can be effective, or augmentation with things like lithium, with sometimes with antipsychotics, sometimes with T3, triiodothyronine, and multiple other sort of augmentation strategies. But the mainstay are the SSRIs, and I would say SNRIs. You really do want to be mindful of potential drug-drug interactions with, particularly with paroxetine, fluvoxamine, and fluoxetine, and fluoxetine, yes. Medications such as bupropion, which is a very versatile drug, has multiple uses, as well as Lexapro and sertraline are generally considered good starter drugs. For people with cardiac conditions or suicide risk, you want to be careful about using tricyclic antidepressants. Be mindful that tricyclics can worsen cognitive impairment and may, in some cases, cause or trigger anticholinergic delirium, particularly in the elderly. Mirtazapine is a very useful drug. It's good as a solo agent, as a monotherapy, but it's also very effective in combination with SSRIs and SNRIs. So it's a very good augmenting agent. And sometimes, particularly in the elderly or people who have marked psychomotor retardation, or who are medically ill, a short course of psychostimulants such as either the methylphenidates or the amphetamine salts can be very effective. Social treatments, like I mentioned, are important also, because you do want to be mindful that people do live obviously in the real world, and real stressors can trigger or worsen mood symptoms. So to the extent that that the ability exists to intervene or help the person rethink or restructure their lives. Sometimes it might be as simple as changing your relationships or changing your job or, maybe moving somewhere else if you have the ability to. These things can make a significant, or just starting an exercise program can be incredibly important in restoring a sense of agency, moving a person from the state of feeling helpless to a place where they feel like they actually can do something with their lives. Pastoral care, when a person adheres to a faith tradition or is religious, can be very important as can be being part of a congregation where oftentimes there are supports, and then social work can be effective. So we'll stop there. Thank you for your time and attention. So in conclusion, depression is very common, but it's extremely treatable. And people that get the right kind of treatment often recover and go on to live very good quality lives. Thank you.